Hi, this is a review of Chapter 32. There's a lot in this chapter. First of all, cardiovascular disease, the leading cause of death in the United States and the world. So it's kind of a big deal. This chapter goes over veins. Most of this you should already have a grasp of, I believe. Varicose veins being one of the big ones that can lead to venous stasis. Basically can be cured by vein stripping. Here's just a diagram of what's going on there. There's lots of different disease process, genetics, and pregnancy, being overweight that can lead to this. DVTs, we all should be aware of those as well. Worry about those after surgery for sure. People with long periods of standing, pregnant women also are at risk. Superior vena cava syndrome. I've only ever seen this once, unfortunately, or fortunately I should say, because it's not very pretty. These people just have this really swollen neck. Apparently it's usually caused by, or can be caused by cancer, impeding venous return from the head. The child I saw was just a great big clot. With this, it was pretty terrible. Then we get into diseases of the arteries. You can look over this list. We're going to go review them real quickly. Hypertension. So I wanted to point out here that your book says that prehypertension is 120 to 139. That's old. Okay, so we had some new guidelines come out in November of last year. And let me just try and switch onto those. Oops, that's not good. So, let me move this thing around. I've got a link to those in your things, but these are the new guidelines that came out from the American College of Cardiologists, I think that's a group, yep, and the American Heart Association. That basically JNC8, which is the guidelines that are in your book, replaced JNC7. Well, JNC9 hasn't come out. This one has, so it's kind of like JNC8 and a half, which is kind of a middle between the two older guidelines. So let me just kind of go here. This is the newer guidelines here, where JNC7 was up to 120 was the upper limits of normal. Okay? JNC8, 140 was the upper limits of normal. JNC8 and a half, or whatever we're calling these, 120 is the upper limits of normal. So they've kind of like split the middle between 7 and 8, which is probably more realistic. If you read the guidelines closely, you'll see that older people are allowed to have slightly higher blood pressures. And there's also updated treatment guidelines, so make sure you read that. The information in your book, like I said, is outdated. Primary hypertension, the majority cause of hypertension. We don't really know why this is caused, probably heredity, whatever else. We know that, for instance, African Americans are at much higher risk for hypertension. So there's, got to be some sort of inherited pattern for that. Secondary hypertension is related to another underlying systemic disease or medications. Okay. Just be aware, if you have someone that's all of a sudden developed hypertension, they hadn't been hypertensive, then they all of a sudden, their blood pressure's high. Think about if you've started any new medications, okay? For instance, if you get someone that's on thyroid medication and you have overshot their thyroxine, they will develop hypertension. Don't treat the hypertension, go down on the thyroid medicine. All right, some of the other risk factors for that, of course, the older you get, the more likely. If you're African American, if you have less salt intake. This should be kind of going through all that pretty easy for you. This starts to get into metabolic syndrome with their insulin resistance. Just the diagnosis. Like I said, the treatment, it's pretty much the first line of treatment is diet and exercise and decreasing your sodium. Stopping to smoke. Just the normal things that you would tell most people to do anyways, but this does give you a little bit of ammunition sometimes to get people to do what they're supposed to do. Then the pharmaceutical therapies, pretty much unchanged, but there again, they are outlined in those guidelines, so just make sure you take a look at them. Orthostatic hypotension, the definition of that. I see a lot of that, especially in younger female or teenagers. They don't eat, they're not drinking enough, they get up too quickly, they feel faint. It's really more like a pseudo thing because we just treat it with, make sure you eat something and drink something and get up slowly type thing. Aneurysms, there's a bunch of different kinds of aneurysms that you can get. None of them are good. The aortic aneurysm is, I think this is hilarious, asymptomatic until it ruptures. Then it won't be symptomatic for long, just saying. Treatment, of course, keeping the blood pressure low, resecting the aneurysm if you can, or at a certain point. Of course, we're not going to be doing that. Embolisms. Once again, I think most of you guys are aware of these. Also, not good. Peripheral vascular disease. A lot of smoking, a lot of diabetes, that sort of thing. Oh, this Buerger's disease. I did have a picture of that on here. Let me go to that. Okay, this is for young men smoking. So basically stop smoking, exercise, but pretty significant. They can lose toes and that sort of thing, so definitely want to be aware of that. Alrighty. Let's move this back over here. The next one on here is Raynaud's syndrome or phenomenon or disease. These people will have like white fingers usually, especially if they're cold or stressed. Basically, you can tell them, keep their fingers warm, drink plenty of fluids, quit smoking, anything that smoking causes peripheral vasoconstriction. So it's one of the many reasons why smoking is not good for you. Atherosclerosis, you should be aware of this. I hate this picture. I think it's awful. This is just talking about what's happening, the cellular injury type thing going on. So diet, exercise, once again, if the numbers get into a certain range, and you can look those up as well because it kind of depends on how long they've been and all that stuff. You will start a statin. We'll talk about that during pharmacology next semester. Coronary artery disease, atherosclerosis. These are some of the risk factors for it. Kind of go through that. I think most of you guys are aware of this, unfortunately. When we talk about a lipid profile, you talk about LDL, and then one of the things that more and more research is coming out for is that we really need to worry about those very low density lipoproteins. And you don't always get those when you do a lipid profile, so just be aware of that. Then there's also some lipid particles that they can see sometimes, which is more of a specialized test. Typically we're not doing that. I don't work in a cardiology office. I assume they do that in cardiology. And then HDLs, of course, we want those nice and high. If we can, exercise and diet. Sound familiar? Myocardial ischemia. So an MI, and talking about some of the warning signs there with an angina. The treatment for impending or post. Of course, prevention is where we want to go there. So it's diet and exercise, using a statin if you have to. Talk about review the film or review the video I have on the coronary arteries. That'll help you a lot when you think about MIs as far as where they occur and why they're bad. Remember that anterior left descending artery is not a good place to have a heart attack. They call that one the widowmaker because it covers such a large part of the left side of the heart. Talking about repair. EKG changes. I'm not going to go over EKGs because you will have a lecture by someone a lot more knowledgeable about EKGs at an intensive. So, just kind of be aware that ST depression or ST segment elevation, going down or going up, neither one of them are good things, okay? Again, you'll talk about a lot of this when we do our intensive. All right. Some of the infections that we can get in the heart, pericarditis. These folks, once again, are going to be pretty sick. So if you hear any muffled heart sounds, or people are talking about they've got this real severe chest pain or whatever else, you need to, especially if you've got a fever, be very concerned about that. Cardiomyopathies. I've got some different kind of pictures for cardiomyopathies. This is dilated cardiomyopathy. Okay. This is a picture of restricted cardiomyopathy. I think that's right. No, that's hypertrophic cardiomyopathy, sorry. Just because the hypertrophic just means when anything's hyper, it's gotten built up. Sorry. I have a picture here, I think of restricted, yeah. And then there's restricted, where the muscle is it is dilated like that, but it's very, very stiff, so it just doesn't contract well. Okay. Then stenosis versus regurgitation. Of course, stenosis is basically, you think about something stenotic, it's fibrous, it doesn't work well. Regurgitation is basically they're just not shutting correctly for whatever reason, and it allows some backflow. So the valves are there basically to stop backflow into the heart from wherever the blood is going from, or going to. And so if you get backflow, regurgitation, or whatever, you're going to hear it. So you're going to hear a different murmur on physical exam. Okay. So some of the tricuspid regurgitation is super common, just to let you know. Okay, you see that quite a bit. Aortic stenosis, some of these valves have to be replaced. So this is kind of like a normal opened stenotic. So it just doesn't open well, it doesn't close well. It's just it's just fibrous, so just think about that, okay? Mitral valve stenosis, the leading cause is acute rheumatic fever. That's one of the reasons we get worried about strep. So there's just a picture of one. Talked about regurgitation already, just not being able to close right and causing leak. Rheumatic fever is kind of a big deal, and one of the rheumatic fever and also damage to the kidneys are two big reasons that we worry about strep. Okay, even if strep's treated correctly, we cannot guarantee that there won't be damage to the heart or the kidneys. If you have someone, and we'll talk about this with kidneys, I hope, but if you have someone that all of a sudden starts spilling protein in their urine, and maybe their blood pressure is starting to go up or whatever else, you do want to check an ASO titer to see if they've had a recent history of strep. Okay. This is why if someone also has a positive strep test, I always like to record no murmur on that visit or listen to the heart. And if there's murmur, of course, record it, but chances are there won't, so that you'll know if that's a change after they've had strep. And I don't like these pictures. Endocarditis, strep also. So one of the things is like a new murmur. So those new murmurs, you get worried about new murmurs anytime you hear a new murmur on someone. If it's a grade 1 systolic murmur, especially if they've got a fever, you may not worry about it. You can hear those with anemia, fever, pregnancy. About 10% of the population has them. But anything other than that, you definitely get concerned about. And even that, I would definitely document it. And then if it's still there or it's getting worse, then you definitely want to check that out. Okay. Of course, endocarditis is better now that we have antibiotics. Antibiotics are a good thing. And then pericardial effusions and heart failures. Once again, if you hear differences in heart sounds, especially someone that's in distress at all, then we need to check that out sooner than later. Heart failure. So you can have right or left-hearted heart failure. And the best way to think about that is really to think about what the heart is doing. I like this picture's or this slide the best to makes it the most easy. So if the left side of the heart, which pumps out to the body, right, to the aorta and then out to the rest of the body, if the left side of the heart's not working well, where does the blood back up? To the lungs. So you're going to get these kind of symptoms, all right? If the right side that's pumping to the lungs isn't working very well, you're going to get that venous distension and hepatosplenomegalia, and you're going to get more peripheral edema and that sort of thing because it's backing up there. But usually one side, right heart failure is going to lead to left and left's going to lead to the right, so they kind of all get mixed up in the end. But if you get asked about those, just be aware of them. Now, some of the common causes for heart failure is anemia, so that's why we worry about anemia, and hyperthyroidism. That's why we're worried about that. Actually, it's a little better to be hypothyroid, have a little bit of hypothyroid than hyperthyroidism. Hyperthyroidism has a lot more bad effects on your heart, and we'll go through that more when you get to endocrine. Okay. So there's a little bit more about high output heart failure. Dysrhythmias. Now we're going to talk about some of this at the EKG seminar at the intensive, so you'll get more of this. But if you're listening and something doesn't sound right, just get an EKG. They're pretty simple to get. They're not expensive. The biggest things you're going to see is sinus bradycardia, sinus tachycardia, which means it's just a slow heart rate or a fast heart rate, but it's a normal beat. Okay? PACs is probably the dysrhythmia that you're going to hear the most. And this you can get is a premature ventricular contraction. You're going to see this with people that just drink too much caffeine or under stress, don't get enough sleep, that sort of thing. Atrial flutter, you're going to see some of, but atrial fib is actually not that uncommon. That's kind of where the atria is kind of doing its own thing. And it's just going along, and then the ventricle is contracting pretty much at a normal rate behind there. But what you worry about this is blood clots forming in that atria. Okay, some of these other dysrhythmias like ventral fib, you don't have to worry about that in your office, or at least you don't have to worry about that in your office long. That is going to kill you. All right. So sinus block, or first degree and second degree block, you will see that occasionally. Wolff-Parkinson-White, remember we talked about that when we talked about genetic diseases, and we do see that occasionally. So, you know, if you're in doubt, if you're starting a new medication that's going to have some cardiogenic effects, and there's any doubt of a history, or if you're doing a sports exam and there's any doubt of a history, just check an EKG. It's pretty simple. All right. Bed rest, pacers, and oxygen. Yeah. So those are pretty good things. All right. I hope that overview helps. If there's anything that we talked about here, or you saw a name that you don't understand, please make sure you look that up. These are all kind of basic disease processes for the heart. Of course, atherosclerosis is #1 in our American diet. Thank you so much.